Muralidhar Sharma, sir, one of the greatest teachers what we have known him as. Sir, on behalf of Government Ayurveda Medical College, Principal, all the faculty of SHALYA, all the students, all the PG scholars, we would like to welcome you for this session, sir. And
Thank you.
Thank you, sir. Thank you. Nagashri, will you continue?
Thank you, sir. Thank you for the welcome address. Now, I would say a few words about Sharma, sir. Sharma, sir completed his undergraduation from SDM College of Ayurveda, Udupi, and post-graduation in Shalya Tantra from the prestigious Banaras Hindu University, Varanasi, in 1983. Later, he joined as a lecturer at his mother institution, SDM College of Ayurveda, Udupi. His tagline says, "A good surgeon is one who knows how to operate. A better surgeon is one who knows when to operate. And the best surgeon is one who knows when not to operate." And this will be his first word in the class every year. Sir is well known for his simplicity, dedication, intellect, punctuality, and discipline. Sir is the greatest asset to the Ayurveda fraternity and a great contributor to the society by his knowledge and service offered to the students and patients. We are really proud to have you, sir, today. Over to you, sir, on the topic clinical assessment of fracture and management according to Acharya Sushrutha. It is a humble request among all. Everybody else, please keep muted. Don't unmute in the between and speak. You can post the queries in the chat box. We can discuss them in the last. Over to you, sir.
Thank you. Thank you for all that special introduction. I don't know whether I deserve that or not. So anyway, let us start with the topic. The topic is about fractures, clinical assessment and management according to Ayurveda and Sushrutha. Now, before we go into the topic as such, bone tissue, as it is defined in the contemporary science, is defined as a tissue formed of a Haversian system. I think all of you know about that, a Haversian system, and covered by a periosteum. So the periosteum is the living area surrounding the bone, and the Haversian system, it gives you the sufficient the structure, and depending upon the direction of the orientation of this Haversian system, the bone tissue is either mentioned as cortical bone or medullary bone. When the Haversian systems are arranged parallel to each other, that forms the cortical bone. Anyway, the definition of the bone is based upon the microscopic description of the tissues. But Sushruta's perception or Ayurvedic perception of the asthi is not exactly the same. Asthi is the strong, firm tissue in the body which gives the shape. Abhyantaragataihi sarehi yatha tishtanti bhurvaha asti sarehi tata dehaha. So deha dharana is done by the asthi. And hence, it's not only the microscopic structure which identifies the asthi. Instead, a tissue which gives sufficient strength to the body and gives a shape to the body. And hence, the hard structure like the teeth also are asthi, but teeth are not bones. So that is a primary difference. A perception of contemporary science and Ayurvedic perception cannot be the same. And the asthi are categorized based upon their shape as a Kapala, Ruchaka, Taruna, Valaya, Nalaka are the types of asthi based upon their shapes, almost similar to the present day's classification of the bones, like the long bones and the hard medullary bones and so on. And the asthi is a pitruja bhava, so that it gives the sufficient strength. Anyway, we will not go much into the detail, but this introduction is necessary to have some idea about the description of the bhagna in Sushrutha. Now, the hard tissue, the bone tissue, is originating primarily from a cartilage, mesenchymal tissue, embryological development, and gradually it will convert it into a bone tissue by ossification process. A bone would have multiple ossification centers. The important point, I will not go into much of the detail of it, but only that important issue which is necessary to understand the pathology of fractures is the point. Now, this process of a mesenchymal tissue, which gradually becomes cartilaginous, and then there will be deposition of the calcium, and it forms a harder bone structure. This then is regulated by a growth center. Each of the growth center would have an independent blood supply. A bone may have multiple growth centers, and each of these growth centers are separated by a ossification plate in the initial state. And this plate acts as an impervious membrane, and blood supply cannot go across the plate in the beginning. But as the bone grows, this plate will be replaced by the normal bone tissue, and the blood vessels can move across, and the nourishment of the bone can now be supplied by or can be interrelated. Before that, and this process is called as the ossification process. Before this ossification process, each of the growth center would be functioning independently. But after the ossification center, there is an interrelationship between the various areas of the bone, and this has an impact on the wound healing and healing of the fracture and the later consequences. And another important issue is the blood flow in the bone is always in the subperiosteal plane, and that's the only living area. And even the sensory sensations, the nerves also are present only in the periosteal plane, below the periosteum. And the remaining area of the bone doesn't have a nerve tissue, and the living, all the osteoblast cells which allow facilitate the growth of the bone, they move from the periosteal plane to the bone tissue area and then help in deposition of the calcium. The deposition of the calcium in the bone is a continuous process, and it's not a static process, and it's a living tissue. And there's a continuous exchange of the calcium from ionic compartment to the non-ionic compartment, and this is regulated by the acid phosphatase and alkaline phosphatase enzymes. It is not related to the level of the calcium in the blood. It's a continuous exchange mechanism between the ionic calcium, and whatever we say as the calcium assessment done clinically is of the serum calcium level, which is ionic, and the non-ionic bone, non-ionic calcium is deposited in the bone, and there is a continuous exchange. And same way, bone also has a remodeling capacity, in the sense the shape can be altered, and this is altered by a balanced activity between the osteoblasts and the osteoclasts. Osteoblasts are those cells which deposit the calcium and make the bone harden. Osteoclasts are the cells which will remove and the calcium and make the bone somewhat softer, and hence there is always a capability of the bone to remodel depending upon the load on the bone. So bone is a living tissue, and it can change its shape, and there is a continuous exchange of the ions and metabolically active. These are all the important points. Now, I'll just stop at that level about the basic issues of physiology of the bone. Directly coming to the fractures, injury, whenever there is an impact on the bone, it may get fracture. Fracture is defined as a discontinuity of the periosteum. And it's studied based upon the pattern of the trauma, injury. Now, pattern of the trauma are primarily classified as either the direct trauma or the indirect trauma. Direct trauma is a hit where the injury has occurred at the same spot where the trauma has occurred, or where the impact has occurred. It could be just a moving, like a tapping as such, or it could be a crush, like a blunt trauma which happens over the area, where a wider area of the bone could be involved, or it could be a penetrating, and penetrating injury could be, again, the impact could be depending upon the velocity, a low velocity or a high velocity. A high velocity injury can produce multiple pieces of the bone, whereas a low velocity injury may produce a localized crashes. The pieces of the bones produced could be lesser. Similarly, indirect trauma is when the injury has occurred in a point where the trauma has not occurred, somewhere away from the trauma. Like traction, if some bones are pulled at two ends, then the injury could be fracture, could be somewhere in the middle, or it could be like bent angulation. If bone is bent at two ends, it may break up somewhere in the middle, or it could be rotation, or it could be a vertical compression, or it could be a angulation, and so on. The basic difference is whenever there is a fracture due to the indirect trauma, the displacement is decided by the muscles, bone of the muscles around the area of the injury. Whereas when it is a direct trauma, the displacement is decided by the impact of the trauma and the direction of the trauma. Anyway, this is how grossly a bone injury is assessed in the contemporary orthopedic practice. Now, Sushrutha has defined the types of the bhagna and the causes of the bhagna on the same lines. Rather, whatever we say as contemporary is exactly what as Sushrutha has told 3000 years back. The causes of the bhagna, according to Sushrutha, are patadana, pidana, prahara, akshepana, vyala, mridadashana prabhutihi, abhigati visheshehi. Now, patana and prahara, akshepana are the direct trauma, whereas pidana, prahara are the indirect trauma. And this will produce different varieties of the bhagnas. And the bhagna is classified again into two categories as sandhimukta and kandabhagna. Sandhimukta roughly can be assessed as or named as a dislocation of the joint, and kandabhagna are the fractures. The way the classification of the injuries by Sushrutha is much more elaborate than what we study now. Now, sandhimukta are further categorized into 6 varieties, and the kandabhagna is further categorized into 12 varieties. We will go into those also. Now, in the present day orthopedic practice, the fractures are classified based upon the type of the trauma. One, as I have already dealt with, the direct or the indirect, or it also is classified based upon the shape of the fracture line or the complication which has occurred among the other tissues. A simple fracture is a fracture of bone alone, where the other tissues are not involved to a great extent. Comminuted fracture is the one when more than one tissue, bone along with other tissues like muscles, soft tissues, or maybe the skin also is involved. A open fracture is rather a comminuted fracture where the bone tissue has penetrated through the tissue and it can be seen over the surface. Or it also can be classified based upon it can also be classified based upon shape of the fractures too. Shape of the fractures like a transverse fracture or an oblique fracture, or it could be a spiral fracture depending upon the shape of the fracture line. And the shape of the fracture line has an importance in predicting about the duration of the healing and possible complications can occur in healing. A transverse fracture would have a comparatively lesser surface and it will be easy to align the bone or reduce the fracture line. A spiral fracture would have a vaster area of the bone surface for healing, and it will be difficult to manage that, keep the bone fixed in the level. A comminuted fracture is a butterfly injury where a bone tissue is separated, a piece of the bone tissue is separated, would have a complication of the avascularity of this piece of the bone, so on. So the classification is based upon the theoretical, the clinical impact. One more variety of the fracture is a greenstick fracture, where there is no really discontinuity, but the bone may become bent. Usually occurs in the younger age when the bones are softer and the bone may be slightly curved. And there is another fracture, that's a stress fracture. It's again due to a union of multiple micro fractures, which is often due to a stress on the bone, continuous stress on the bone, like marching or walking with heavy weight or so on. During every stress, there could be a small microscopic fracture, but all of them would be merging together, and there would be a mass of new callus tissue formed, and this is called as a fracture. Though technically, it's not a fracture. There may not be a discontinuity of bone, but anyway, that's how the fractures are classified. Now, Sushrutha has described these classic signs in more detail, much more detail than what we have studied in the contemporary system. The sandhimukta, the general clinical signs of the sandhimukta are a difficulty in range of movements of the joint, prasarana, akunchana, vivartana, akshepana, extension, flexion and rotation, or the abduction movements, wherever they are relevant, and when they are not possible to be done to the normal range, that's a sign of the sandhimukta. Ugra rajatvam sparsha asahatvam cha iti samanyam sandhimukta lakshanam. When there is severe pain and a tenderness is the other sign of sandhimukta. Sandhimukta are further classified into the 6. They are Utpishta, Vishpishta, Vivartita, Avakshipta, Atikshipta, Tiryakshipta are the names. Now we will go into each of them. The Utpishta Sandhimukta is when Utpishta Sandhavu Ubheta Shopaha Vedana Pradurbhava Visheshta Snana Prakaraha Vedanaha Ratro Pradurbhavanti. Whenever there is a dislocation of a joint and the bone pieces are overriding over each other and there is a proximal displacement, you will see the swellings on both the sides as you see over this image, where the bone has overridden over each other. each other, and because the whole joint is unstable, and whatever the strength is depending upon the muscles only, and during the sleep, when the muscles are relaxed, naturally the pain will be more. When the patient is awake and the muscles are rigid, at least to a certain extent, the pain is the stability of the joint is maintained by the muscles, and hence there may not be the pain will be slightly better. So this is one of the unique assessment, clinical assessment of the condition, and you do not have such a parallel classification in the contemporary system based upon purely clinical assessment. Anyway, that's about the Utpishta Sandhimukta, where there will be overriding of the bones as such. Now, Vishlishta Sandhimukta is a situation where the joint swelling would be lesser. It is due to a spontaneous reduction of the displacement. Once the dislocation has occurred, and if it gets reduced spontaneously, and very commonly, quite frequently, this kind of incidence occurs in wrist joints. And hence, because there is a spontaneous reduction, it will result in alpaha shopaha. The pain swelling would be comparatively lesser, but the pain will be continuous for the whole life. Vedana sadhatyam sandhi vikriyata. There will be an extension of the movement. The movement will be much more than the normal. And in the case of a spontaneous reduction of the dislocations, confirmation of the pathology is always done by a stress X-ray. Stress X-ray is you will have to push a pressure on the joint and then take the X-ray in a specific position, either towards the abduction or towards the abduction. In any direction, you have to put a stress and then take the X-ray. Then only the confirmation of the diagnosis is possible. And that's exactly what's mentioned by Sushrutha as a sandhi vikriya, where the range of movement would be more than the normal. When Vishesha Kriya is sandhi vikriya, so a spontaneously reduced dislocation with a increased range of movement is the Vishlishta Sandhimukta. Vivartita Sandhimukta is where there will be Sandhi Parshvapamanata Vishama Angata Vedanata. The bone will be displaced to a side and the alignment of the bone is lost. This is again a common phenomena when you have a very complex joint. The complex joint is either it could be like a elbow joint where you have uneven surfaces forming the joint. The trochlea and the capitulum, a capitulum globular structure, trochlea which is somewhat uneven surface structure. Whenever there is a dislocation, the dislocated bone, particularly the coronoid process, goes into the supratrochlear knot and gets locked over there, and it remains in the same position for a long time. And this is exactly what's considered as the Vivartita Sandhimukta, where you have a real serious problem in clinical handling. We'll come to that point later also when we go into the management of the issues. Now, a similar situation can result in posterior dislocation of the hip also. Once there is a dislocation of the hip and the head of the femur gets entangled over the superior surface, that gives the typical clinical presentation of the posterior dislocation. So you will have plenty of such examples where the displacement can remain due to the movement of the bone away from the joint surface. Next of the condition is the avakshipta sandhimukta. Avakshipte sandhi vishleshaha tivra rujatvam. In the avakshipta sandhimukta, the gap between the two bones will be increased and hence the joint becomes more flexible. And virtually, you will have a free range of movement between the two ends of the bones, and this is called as subluxation. In the present day situation, we use the term subluxation. As you see in this image, in the shoulder joint, once there is a dislocation, there is a gap between the superior and the inferior surface. The prominence, biceps prominence is completely lost as such. And this kind of, and the gap between the glenoid surface and the head of the humerus is increased. It is as if the joint is freely moving as such. And that kind of a dislocation is the avakshipta sandhimukta or subluxation injury. Atikshipta is where atikshipte dvayoho sandhyasnoho atikrantata vedanata, where the bone gets displaced more proximally, hits into the proximal area, or it penetrates through the other softer structures, and hence there will be severe pain and the prognosis is poor. And this is exactly what you see in case of what we call as a central dislocation. Central dislocation is in case of the hip, it occurs when the head of the femur penetrates into the hip bone and the surface is cracked. Head penetrates into the surface, that produces the central dislocation, where there will be multiple fractures also. And this becomes one of the most severe conditions. Management will be always difficult in such conditions. Or another mechanism where you can see a similarly Sandhishna Hotikrantata would be in case of buttonholing injury. Buttonholing injury is very commonly seen in case of phalangeal joints, when there is a displacement of the phalanx and it penetrates through the joint capsule. The piece of the bone, particularly the distal phalanx, penetrates through this joint capsule and remains dislocated, and that's considered as buttonhole injury, where again the management will become difficult due to the complexity of the joint. So that's the Adhikshipta Sandhimukta. Tiryakshipte tu ekasti parshvapramanam atyartham vedanacha. This again occurs in a complex joint phenomena where there will be a diastasis. The gap between the two bones is increased, like a tibiofibular, radioulnar dislocation along with the elbow joint dislocation. In the elbow joint dislocation, one of the possible situation is a proximal displacement and the coronoid process may get entangled. At the same time, the proximal radioulnar joint, which is an annular joint, which also may give away. And if this happens, that becomes again most difficult condition to manage. And as a result of that, you will see a depression over the surface. Over the surface, that depression, the gap is visible, seen, and the swelling is more on the forearm. And clinically, this can be identified as one of the complex dislocations as such, and that's the Tiryakshipta Sandhimukta as such. These are the types of the Sandhimukta or varieties of dislocation. Then the Kanda Bhagna or the Bhagna are, the clinical signs them are Shwet Bahulyam, where there will be a swelling, Spandana Vivartana Sparsha Asahishnutvam, a movement, intolerance of any of the movement, which either spontaneous movement or induced movements, Avpetamane Shabdaha, a sense of crepitus, Sastangata, a flail joint movement, Vivitha Vedana Pradurbaha, Sarvas Avastha, Sutana Sharmalabha. A patient will not find any comfort in any of the position, and then he adopts to a decubitus of position. That's the decubitus is a Sarvasa Avastha, na Sharmalabha. Patient will not find comfort in any of the other positions and hence adopts to a position where he can find a comfort. These are the signs of the fracture, and this description is exactly the same if you read any contemporary orthopedic textbooks. And the Kanda Bhagna are further categorized into 12, each of them Karkata, Rashvakarnak, etc. We will try to see each of these assets. Now, when I say decubitus or Sarvasa Avastha Suchana Sharmalabha, the practical clinical application of this would be in many conditions where by looking at the position of the affected area, you can make the diagnosis. When you have a patient with a fall and then pain in the hip joint and not able to move on himself, he is not bearing the weight. And if you look at the position of the leg kept over, if the position of the leg is slightly extroverted and the toe is actually externally rotated, the leg is externally rotated, it's an obvious sign of fracture of the neck of the femur. Whereas if the hip is slightly flexed and the toe is towards the internal rotated side, then it's an obvious dislocated hip. Sarvasa Avastha Suchana Sharmalabha. The implication of that sentence is by looking at the clinical position of the patient, you can make the diagnosis, and there can be plenty of such examples. I have given just one example about it. Now we will go into the details of each of these Kanda Bhagna. The first of them is the Karkataka Bhagna. Karkataka Bhagna is where the feature should be Sammudam Upayato Asti Madhya Bhagnam Granthiriva Unnatam, where as a result of the fracture, there is a proximal displacement, commonly seen in case of the Colles fracture, very famous popular fracture injury, where there will be a shortening of the bone. After the fracture, the proximal and the distal pieces of the bones, they tend to get merged together, they will overlap over each other, and hence there will be a local swelling. And in these conditions, usually the union occurs very easily there will union always occurs rather, there will be never a non-union, but non-union is possible. And whenever you go for the correction, it's important to ensure that this sharpening is corrected by a traction as such. And that's the Karkatagna, Samudam, Bhayato, Asti Madhya Bhagnam, Granthiriva Unnatam. Then Ashwakarna Badam, Udgatam Ashwakarnakam. Then a fracture injury produces a sharp penetrating tip at the site of the injury. That's considered as a Ashwakarna. I don't know how Sushrutha could see this without an X-ray or not, but with the X-ray image, that Ashwakarna image can be easily made out. A pointed and an oblique fracture in a long bone, where the end of the bone is very much pointed. And of course, it's a complete fracture, and hence the displacement would be comparatively more. And management will be, you have to ensure that these oblique surfaces, they are aligned together, which is often comparatively difficult. Anyway, that's about one of the issues. Next is the Churnita Badna. Svarshamanam Shabdavad Churnitam Navacheta. A Churnita Badna is a comminuted fracture, and where the pieces of the bones are floating in a blood clot. It's not simply a comminuted. Comminuted could be of different varieties. We will come to that part. Sushrutha has identified a separate classification of comminuted fracture. Comminuted fracture with a floating pieces of the bone is the Churnita Badna, and hence whenever you palpate over the area, you will have that feeling of sense of crepitus, or a ball of worm-like feeling. Ball of worm-like feeling is the word which is mentioned in the contemporary textbooks. It can be in any of the bones, but more common in case of the medullary bones like the heels acid. Then the Pichita Badna is where the bone becomes flattened, and often essentially in the flat bones or medullary bones you will see this kind of a situation. Pichitam Prututam Gatam Analpashokam, where the bone becomes flattened and the elevation or the dimension of the bone is reduced, and comparatively the swelling is lesser. And this is exactly the same phenomena as you see in case of vertebral body fractures, particularly when the trauma is in the longitudinal direction. When a person falls over the body in a straight direction, and the body weight acts in the longitudinal direction over the vertebral bodies, that results in a compression fracture of the vertebral body. The Pichita Badna is the compression fracture as such. Parshvayoho asti hinodgatam asti chalitam. Asti chalita is a butterfly injury where a small piece of the bone is separated. Now, it's an incomplete fracture, so and often occurs due to a penetrating trauma. When there is a penetrating trauma and then a piece of the bone is separated. Now, in this condition, though the continuity of the bone is somewhat maintained, there will be a small portion of the bone which is left over and it's kept continuous. So, clinically, the visible impairment of the functions will not be very significant, very sure. The patients may still be able to bear the weight upon the continuity of the bone can be still be assessed, but a gap is formed due to a piece of the bone which is separated, and this would become difficult because the area of this bone may not have a sufficient blood supply. There may not be a nutrient phenomena at the area, and hence it may become avascular, and in the long run it can produce more complications, and it's one of the indications for the surgical intervention now. Anyway, Sushrutha has considered asti chalita bone fracture also as one of the difficult conditions to be managed, and that's exactly what Sushrutha described as asti chalita, where parshvayoho asti hinam, when a piece of the bone has become displaced, and udgatam, it tends to get displaced as such. Then Vegate Prakampamanam Kandabhagnam. Kandabhagna is a complete fracture, and as a result of that, there is a flail joint movement. We use the word flail joint movement. Sushrutha has used Velate Prakampamanam. It acts like a creeper when you try to move. The limb is moved, it bends like a valli. So that's exactly the description as such, and it's a complete fracture. Important is another issue. Kandabhagna word can be applied for all varieties of the pleural fractures as well as specific to a complete fracture, transverse fracture, where there is a gap formed and there is not much of a proximal displacement. Anyway, next is Majjanugata, where अस्त्यवयवम् अस्ति मध्ये अनुप्रविश्य मज्जानम् उन्नश्यति इति मज्जानुगतम्. Madhyamagata is where a bone piece gets penetrated into the proximal area and results in displacement of the bone marrow. Now that bone marrow displacement and fat embolism now is considered as a complication of any of the fracture. Particularly the risk is more when longer bones and thicker bones are involved. It's not a type of the fracture. A present day situation, a fat embolism occurs, which occurs as a complication of the fracture, is considered as a complication. And we will always take steps to prevent that, and it's not considered as a type of the fracture, whereas Sushrutha has considered this as a type of the fracture as such. Then Asti Nisheshara Chinnam Atipathikam, where there is a complete separation of the bone as long as well as there is a tissue, other tissues also involved, and a near amputation like situation where the limb is almost separated, either completely separated or almost separated. It's considered as Atipathika Bagna. It's again a complex injury. It's not only the bone injury, and you need to have a multi-systemic approach to deal with such patients. It's not only the bone injury, you'll have the injury of all the other tissues also, and whether you can salvage the limb or not would be depending upon your facilities to have multi-systemic approach as such, multidisciplinary approach as such. Then Ahabugnam Avinukta Asti Vakrabagnam. Vakra is exactly the Greenstick fracture, where there is no complete separation of the bone, but the bone is slightly bent. That's the Greenstick fracture as such. Anyatara Avashishtam Asti Chinnam. Chinnabagna and Asti Chalita. These are, both of them are butterfly injuries only, but the only difference is in case of the Asti Chalita Bagna, the portion of the bone left over is very thin, whereas in case of the Chinna Bagna, the portion of the bone left over is bigger and the butterfly is smaller. The piece of the bone is smaller. Now, the basic issue in such conditions is clinically, these are all problematic conditions where the clinical signs will not be very severe, but long-term complications will be more. In a case where there is a butterfly injury with a relatively smaller piece of the bone separated, in severity of the clinical symptoms at the time of the injury might not be very severe, but as this small piece has a lesser chance of growing and it has a higher chance of becoming avascular, the long-term complications of degeneration would be more, and most of the times the patients would have a lifelong suffering in such condition, and hence Sushrutha has considered this as a separate type of the fracture as a Chinnabagna. Though in the present day situation, you do not have a separate category of such a fracture named as a classified fracture. Then another variety of the comminuted fracture mentioned by Sushrutha is the Patita Bagna. In the Patita Bagna, Anu Bahu Vidaritam Cha, where there will be multiple small pieces as such. The Churnita and the Patita differences are only that much. In a Churnita Bagna, the pieces of the bones are floating in a blood clot, and hence the management will be, you will have to ensure that the hematoma doesn't occur. Whereas where it's not much of a huge amount of the bleeding occurring at the area, the piece of the bones may not be really floating, and management, of course, it has to deal with that, but hematoma may not be a complication. Other complications remain as such, and hence it's a comminuted fracture. In the present day situation, we do not categorize them into two, a comminuted fracture with a blood clot or without blood clot, whereas Sushrutha had made out that difference as the Churnita and the Patita as such. Then Shukapurnami Madhatam Vipulam Sputitam iti. Sputita Bagna is a cracked teeth. A injury to the teeth now is not considered as a orthopedic discipline. It's in the dentistry and it's not named as a fracture. But Sushrutha has considered this as a Bagna asset. Anyway, that's about the types, 12 types of the Kandavagna. The fractures also can be depending upon type of the bone, as Tarunasthini Namyante, Rajyante Nalakanija. Tarunasthi can be having a Greenstick fracture. It may bend, and the long bones, they tend to get split as such. Kapalasthi, the flat bones, they tend to have a crack as such. And Ruchanti Sputakanija, the teeth tend to get cracked in vertical direction. The clinical signs of the fracture, as you read in the contemporary textbook, are exactly the same as mentioned by Sushrutha. Summary of all the 12 is here in what you see as an abnormal movement of a limb, crepitus, deformity, swelling, and the impaired function. The examination of a fracture, whenever a patient comes to with a sign of fracture, you will have to examine all the clinical signs, local as well as the palpatory signs. And the most important part is, it's not only the local signs which have to be assessed, the general condition of the patient also has to be assessed. A fracture can accompany other complications too. The other complications can be directly related to the fracture, like a pain producing a neurogenic shock, hemorrhage producing a hypovolemic shock, or a displaced bone piece penetrating into any other vital organs of the body and producing the complications. They could be one of the complications, local complications as a result of the fracture injury, or even the sepsis which can occur as a result of the fracture also have to be assessed. So clinical examination of a fracture doesn't end up with only the clinical signs of the fracture. It also has to assess all the other possible complications as such. We will not go into much of the detail of that issue. Then it's not enough if you have a clinical assessment. You need to have confirmation of the fracture with the radiological examination. The radiological examination, the popular tool is a plain X-ray, but many times a plain X-ray may not be sufficient. If the fracture is supposed to be a minor injury and in a smaller bone, it may be that a plain X-ray may miss that fracture conditions, and hence you may need to have a CT scan. Even in the plain X-ray, position of the body in which the X-ray has to be taken is very crucial. If you do not adopt a proper position during the exposure to the X-ray, you may miss the diagnosis. The clinical assessment of the fracture and a possible suspicion of the condition, a possible probable diagnosis to be made, and a selection of the investigation procedure which is suitable to that condition is another issue. We will not go into more detail of that, but I just sensitize that it's not that you do the investigation routinely for all patients the same. The selection would be based upon the possible clinical diagnosis. So either it could be a plain X-ray or it could be a CT or MRI if you are suspecting a soft tissue injury. Now that's about the clinical assessment of the fracture as such. The next part which we discuss is the phenomena of a fracture healing. A fracture healing is a spontaneous procedure. It occurs spontaneously by the body, and virtually there is no technique by which the healing can be induced. Healing is an internal process. So all that what we have to do is facilitate that natural process of the healing. And that natural process of the healing which occurs in the fracture would be, once there is a fracture area, that gap would be filled by a blood clot. And this is the first stage. And that blood clot, gradually will be replaced by the healing tissue, and that healing tissue, where there will be irregular mass of calcium, and hence it is called as callus. So callus formation is one stage of the healing process, and once the callus is formed, the bone may gain sufficient mechanical strength, and that mechanical strength gives you, or we identify that stage as a union of the fracture. So once the callus has occurred, we say that the fracture has united. On an average, the union never occurs before 3 weeks. The minimum time taken for the union to occur, the callus to be formed, is 3 weeks. And to make the duration shorter, the shortest possible is 3 weeks. And to keep it shorter, what you need to do is the size of the clot should be as small as possible, and the clot should be stable. There should be no movement between the two ends of the bones till the callus is formed. So you need to immobilize, you need to reduce the fracture. The fracture, reduction of the fracture in the sense, an attempt to reduce the gap, reduce the size of the blood clot, and you have to immobilize the fracture. Then you can achieve a healing at the shortest possible time. So the shortest possible time for the union is 3 weeks. Now once the callus is formed, the bone can function normally, but structurally it is not yet normal. And that structural normality occurs continuously as by a remodeling process, and gradually that callus tissue is replaced by the Haversian system of the bone, and the bone may become normal. It may take minimum of 6 months. The least duration for the fracture to heal is 6 months, and hence all that care to be taken during the management of a fracture would be up to about 6 months as such. A radiological image of the same During the immediate after fracture, blood clot cannot be seen in the X-ray, it's seen as a gap. Gradually, as the callus is formed, you can see that irregular calcification mass formed as a, and that whole callus filling up the gap of the bone when we say the fracture has united. Then gradually that callus is replaced by the normal bone tissue. You can see the periosteum developing and the difference between the cortical and the medullary bone structures formed when we say the fracture has a healed as such. Now, to facilitate these fractures, you need to see that the healing process is not affected by any of the other intervening components, and that intervening issues which have to be prevented, or the whole management of the fracture would be to prevent these complications which can postpone or which can delay or which can affect the process of the healing. And they are those factors which can affect the healing process are either an undue movement between the two ends of the bone, or a vascularity, improper blood flow to the area. If there is a tissue other than that of the bone tissue, other than that of the clot in between the two bones endings, again that may affect the healing quite naturally, because the callus cannot be formed. Other tissues could be either a muscle, tendon, or a nerve which comes in between the two ends of the fractures. It can affect the healing. Infection is another issue. If a general condition of the patient, either nourishment or absence of any other systemic illness, are the other factors which also decide like whether healing will occur properly or not. So all that management of the fracture would be to prevent these possible complications and facilitate an environment where the normal healing would be progressing as such. The common complications which can occur could be either that could be malunion in the sense the bone may get united, but the union may not have the normal anatomical configuration, and hence the functional function may not be gained properly. Or a non-union where the bone may fail to unite together. Sepsis, as usual in any of the other complications, a pus forming. Then contractures which occur as a result of the fracture injury, where either the muscles may get contracted or the joint may become totally displaced as such. Joint may get displaced as such, there may not be any movement between the joints as such. The joints may get fixed with each other, which we call as arthrodesis, or a compartment syndrome, like where as the fracture unites and heals, there could be some increased gap and any structure in between, either a vessel, blood vessel, or a nerve may get compressed between, and then can produce syndromes. These are called as compartment syndromes, are the usual common complications of the fracture. So management of the fracture would be to prevent these complications. Now, to define like what's non-union and malunion. A non-union is a failure of the bone to get united even after 6 months of proper management, immobilization technique. When it fails, then it's considered as non-union. Malunion is when the union has occurred in an abnormal direction and your normal configuration is not maintained. Contractures, there are two varieties of the contractures which can occur due to the fracture injury. Workman's contracture and Dupuytren's contracture. Workman's contracture is due to vascular injury when the blood vessels are compressed and hence the muscles are fibrous. Dupuytren's is due to adhesions between the muscle and the bone tissue. And anyway, a fracture can result in the complications of the contractures, and management of these also would be different. Workman's, it requires a correction of the blood flow, whereas the Dupuytren's, due to the adhesion between the muscle and the tendon, muscle and the bone, the movement may become abnormal and virtually it's very difficult to manage. Sepsis can result in osteomyelitis, where there can be a pus discharging sinus and the sequestrum may get separated in due course of time, and it can be quite troublesome complication. Compartment syndrome is when the nerve is compressed between the two nerve, or a blood vessel is compressed due to the abnormal configuration produced as a result of the fracture injury, is the compartment syndrome. And whenever a patient comes to you with a fracture, the management would be, it's not only the fracture management which has to be done, you will have to consider the other issues. A patient coming to with a suspected fracture, the first of the thing is you have to assess the general condition of the patient, ensure that the patient continues to live, because many of the patients of fracture may have other serious complications. It could be a blockage of the respiratory tract, injury to the brain, or so on. So you need to give a first aid so that the patient's vitals are maintained properly. Every patient of fracture will be quite severe, painful, and hence management of the pain is another important part of the management of assessment of the fracture. A fracture may have a complication of bleeding. Either it could be a visible external bleeding or it could be a concealed bleeding. So it needs to be assessed and that bleeding has to be taken care of. And as we have just referred to, the fat embolism is a complication which can occur due to any gross fractures and that need to be prevented. And what we usually do is a heavy molecular weight dextran is given intravenously. Then accompanied injuries are even along with the fracture, there could be the other injuries to the other vital organs like lungs or maybe the bladder or maybe kidneys and so on. So that needs to be assessed. So we will not go into the detail of these steps because we are dealing with only the fracture management. These are to be understood as such, but they are the essential part. What we will deal with to a certain extent would be the next two, the reduction and immobilization, which could be either by an external or internal fixation and rehabilitation. When I say this, is not to undermine the importance of the other first 5 steps. These other first 5 steps are very crucial, and only when these are done properly, you have an opportunity to go into the next step, the real management of the fracture, of reduction and immobilization. But for the sake of being brief, we will avoid that those steps will directly go into the management of the fracture. Now, the technique of management of the fracture basically is to reduce the fracture, and it can be achieved by anchanehi, pidaneshchiva, sankshepehi, bandhanestata, sandhin, sharire, sarvam, swachalana, prachalanapi. The bhagna sthapanopayas are anchana, that's the traction. When there is a proximal displacement, it needs to be pulled apart, or it could be sankshepana, where you will have to push the 2 ends of the bone when the gap is more, as in case of a subluxation injury, or pidana, a local manipulation, where there is a displacement to a side or so on, lateral or medial displacement that needs to be corrected. Then the bandhana, the management with immobilization has to be done. Or the basic principle is that wherever there is a abnormality, a displacement occurring as a result of the fracture, that needs to be corrected by putting a effort or a pressure in the opposite side. Avanamitam unnasheta, if the bone is bent deep towards the depth as such, then it should be elevated. Unnatam javapeda, if the bone is elevated, it should be depressed. Anched atikshiptam, if there is a overlapping, that should be, traction should be given. Adavatam parivartayeta. Now, these sentences of Sushrutha, they are the eternal principles. Anytime, maybe in now as well as in future, the management of the fracture would consider only these steps. The difference comes in the technology which you use. It could be simple manual technology. You may use a sophisticated instrument to achieve these technologies, but basically the management is exactly the same. Either it could be a crude step where you may make use of your indirect assessment of the immobilization. You may use a sophisticated instrument, or you may use an open approach where you can directly see the bone and reduce the fracture as such. Now, ultimately, the next part is bandhana. Bandhana is the immobilization. Now, word bandhana in Sushrutha has a 2 contexts: bandhana for the fracture as well as bandhana for the vrana. Vrana bandhana is also a part of the same bandhana only, but in case of the fracture, the bandhana is slightly different from the vrana bandhana. The materials used for vrana bandhana in Sushrutha's period, it's about 5,000 years back, would be barks of the tree. The technique of bandaging or splints used by Sushrutha and the technique of bandaging in Sushrutha's period was slightly different from what we do now, but principally it is the same. The technique used in Sushrutha's period were use the bark of the tree, different varieties of tree, madhuka, udumbara, ashwatha, palasha, etc. And these barks of the tree would be applied over the surface of the body, and they are firmly tied with a gap. And in between that gap, the gap is filled with the manjista, madhuka, raktachandana, shatadauta, and shalipista. The floor of the rice is applied in between so that the gap is filled up. Then during the course, to reduce the pain and to facilitate the healing, you may use a kashaya or taila in between to facilitate the healing as such. barks of the tree, it could be any of that which could be used, and these could be tied with a gap in between, and this gap in between is used for pouring of the medications in between. Application of the medications in between is a unique concept of Sushrutha's idea. Now, in the present day situation, you may not use the barks of the tree, it totally becomes troublesome, but you may have synthetic materials like fiberglass which can replace the barks, and then you may have more sophisticated strappers which can hold the area, and the management could be comparatively easier. And that doesn't make a huge difference whether you use a original bark of the tree or whether you use a fiberglass, makes very little difference as such. Or it could be, now you may have the other way, use of other splints also. It's not only the fiber or the, it could be metallic splints which could be used as such, or some modification of the splints like finger splints. All of them are the same category of bandhana dravya. Though Sushrutha might not have mentioned their names, these are still under the purview of what Sushrutha has said, or the most popular, which is quite now used, is the plaster of Paris. Plaster of Paris, the major advantage of the plaster of Paris is it's very flexible and it can adapt the shape of the body so easily, much easier than the barks of the tree used by Sushrutha. But otherwise, it has all the same advantages. The disadvantages of the plaster of Paris is once it is applied, it takes around, it gets hardened within a short period, and you will not get a gap to deal with the tissue in between. If there is a gap, wound there, a compound injury, it will be difficult to manage. Whereas if you adopt the Sushrutha's technique, naturally you have the advantage of managing the wound in between, but comparatively the whole technique will be difficult, more cumbersome, time consuming, may not be as easy as that of the plaster. So you may select any of the choice, but still it is the same principle. Now, other principles of the management of Sushrutha which have stood the test of time are, once you have applied this immobilization, the bandage, the splint is applied, it's not kept till the period of union, that's not for the whole duration of the union. Instead, it has to be changed at intervals. It could be like saptahat, other saptahat, saumesh rutush bandhanam. In cold seasons, it could be once in a week, or it could be once in 3 days in hot summer. And this is to maintain the hygiene. It's not only the hygiene as such, replacing or changing the bandages at regular intervals in between always helps in reduction of the complications like rigidity occurring. Now, gradually the trend is changing. Earlier in the orthopedic management, the idea was once you have applied there's a POP, plaster of Paris, minimum for 3 weeks it would not be removed. But now the idea is changing. Gradually there is a discipline of opening that bandage once in a week and facilitating some amount of the movement which can reduce the complication of the rigidity. So concept of Sushrutha is a future ready concept. It's not the present only. Anyway, that's about one of the issues. Then the bandhana has to be an optimal bandhana which should not produce more stress on the area, and the healing should be promoted. Now, certain of the special techniques are special points of management of the fracture, current orthopedic principles and what Sushrutha has said. One of the important issue is, and always troublesome would be, a spontaneous reduced conditions. Spontaneous reduced injuries are always quite troublesome conditions practically, because patient would not have a severe symptom at the time of the injury, displacement will be minimal, and most of the times the patient would neglect that area at that time. But in long run, the patient would have more troublesome complications, and most of the times it will be a lifelong complication. And hence, the general discipline now is to consider every case as a potential displacement, and you have to confirm whether there is a displacement or not by a stress X-ray. Even if there is no confirmation of the displacement, you have to consider this as a potential case of displacement, and immobilization has to be done. This is exactly what Sushrutha has said in case of abhigate hrite sandhi swam yati prakritim punah. If there is after the trauma, the joint gets again gets repositioned, you have to immobilize with the grisa pattena vesitva yathabidi, grisa patta used. Or similarly, in those dislocations where there is swelling is comparatively minimal, deformity is minimal, instead of any rigorous management, you keep the joint in the same position and a partial immobilization with a Grita patta, the crepe bandage, a elastic bandage, he applied over the cloth would make it more elastic, but maybe the crepe bandage which is available would be much more convenient than the Grita patta of Sushrutha, but a elastic bandage could be used for a partial immobilization. Then another of the technique which is often used in case of the fracture management is the traction. Traction now can be of different varieties. Either it could be traction over the surface of the body, that's but skin traction, where you can apply the traction over the skin, or it could be a skeletal traction where you may drive a nail across the bone and then put the traction. Now, the idea of multiple tractions where you may use a pulley and then the direction of the traction can be modified is a unique idea of Sushrutha, and this is mentioned by Sushrutha as a Chakra Yoga. Matiman Chakra Yogena Anched Urvasinigatam Sputitam Pichitam Japi Badnya Purvat Pishakar. So you will have to have a traction, though Sushrutha has not given you the detail of that skeletal and skin traction separately. But idea of a Chakra Yoga, a pulley being used to change the direction of the traction, is a unique idea of Sushrutha. In the present day situation, you may have many more modifications, technological advancement of these tractions of different varieties, like the Thomas splint where you may use multiple traction points as such. Now, it's not only the traction where you apply the force in one direction. It could be a traction and counteraction techniques which can facilitate. We use the term facilitated traction. Either is facilitated traction would be when, like in a shoulder joint dislocation, you may put a traction in one assistant would be pulling the traction, giving the traction on one side, and the other traction is given in the opposite side, so that you will have an advantage of facilitating this. Or the gap between the two bones can be enhanced by a bandage over there. This is what we call as the countertraction techniques. Sushrutha also gives you the similar examples when he describes about Musalena Utkishivet Kaksham Amsa Sandovisam Hate in a Kaksha, that's the shoulder joint dislocation. To facilitate, you may use a musala, a hard pounding rod. Now, it may not be a pounding rod exactly which is used now. Instead, it could be any of the other. You may use a cloth piece and then pull it apart, either by an assistant or it can be done by the same surgeon himself can do that. So you have certain techniques of countertraction also. So that's the basic idea of countertraction. Or a countertraction could be by making use of the body weight itself. This also is a unique idea of Sushrutha. Anche durdum adho api katibhagnam tumanavam. In case of katibhagna, a fracture of the pelvic bone, to facilitate the traction and the countertraction, what Sushrutha says is you have to have two persons, one assistant pulling the patient from the head side and the other assistant pulling the patient from the leg side, so that there is a constant traction produced. But this is cumbersome. To have two assistants continuously to put the traction would be cumbersome. A modification which is now used is a hammock bandage. In a hammock bandage, the patient is nursed in a hammock, and the weight of the body on the head side and weight of the body on the leg side would be acting as a traction and the counter traction. So this is the technical modification which you see, but basic idea of putting the traction in two directions as a counter traction is a Sushrutha's idea. So anyway, these are certain of the varieties of the tractions which you may use. Which you may use now as a. These are the varieties of the traction which could be used now. Modification of what Sushrutha has said, only the issue is that Sushrutha has not given the details to the same extent as you use it now. Technological advances of modifications are what we see now. A traction with the leverage also is another of the idea. It's simply you will have to put a pressure on one side and pull it on the other side, so that you can get that facilitation of the force, multiplication of the force is possible, where you can use two different directional forces, which is what we call as the traction with the leverage. This also is exactly the same idea of Sushrutha, Musala Asti. The Cocker's maneuver which we use is again a modification of the same. where you may give multiple directional tractions. Initially, you will be pulling the bone apart, and then the internal flexion of the shoulder is done. Anyway, the different varieties of the tractions are now available, though Sushrutha has not used mentioned them. The another modification of the same idea of the traction which is now used is external fixation by using the skeletal frames. So instead of using a pulley, Chakra Yoga, now you have a facility of using a frame where the nails are driven across the bone and they are supported by a parallel rod or a parallel lever which can be used to change the direction as well as either pull or push so that the correction can be done, which makes somewhat technically sophisticated issue. And Elizarus is a more sophisticated technique of the same skeletal frame technique where the correction can be more accurate with the multi-directional correction. Now, in addition to what Sushrutha has mentioned, whatever we have now extra would be the internal fixation. Sushrutha has not mentioned about the internal fixation as such. In the current situation, you have an extra facility where you can make an incision, handle the bone fracture directly, and maintain the continuity of the bone by fixing a nail across the bone through the medulla, intramedullary nail, or it could be small screws and plates where the pieces of the bones can be held together, and the reduction is achieved by these fixations. Screws or plates could be used, or it could be Kirshner's wires which could be used to bind these pieces of bones together, or it could be prosthesis where a bone can be replaced by a totally artificial structure, or at times it could be the whole limb which could be displaced. These are certain of the sophistications which are not really mentioned by Sushrutha, but they are now adopted, and that makes a slight difference between the total outcome of the fractures. Now, anyway, some more of the principles which are mentioned by Sushrutha is the stretching splints, the splints which can continuously stretch as such, keep the stretch continuously, which are now very popular as soft cervical collars. These are mentioned originally by Sushrutha in case of the Griva Bhagna, Grivasti Bhagna, Grivayam, Vivruttayam, Prabhishtayam, Adhokriva, Avatavadhanoscha Pragrihya Unnameyat Naram, Tasak Kushan Samam Dattva Vastra Pattena Vestayata. You will have to have a Vastra Patta in the neck area, and then the person has to be kept immobilized for 7 days as such. So that idea is originally of Sushrutha. Another technological sophistication of Sushrutha is the fracture bed. A fracture bed mentioned by Sushrutha is in case of the fractures of either the femur or the tibia, where there will be nails across the fractured ends of bones, and the patient is made to lie down on the bed with the support over as such. Jangha Guru Bhagnanam Kapata Shayanam Hitam. Kapata Shayana is the word used there. Kirakaha Bandhanartham Cha Pancha Karyaha Janata Yatha Nachalanam Tasya Bhagnasya Kriyate Tata Sandehe Ubayato Dvau Tarecha Ekascha Kirakaha. So you will have to have two nails across on both the ends of the bones, and the body is fixed over the bed as such. In the present day situation, fracture beds are now used only in the operating rooms. In the operating rooms during the reduction, during surgery, to keep the bones, we use the fracture beds regularly, but they are not used in the regular clinical practice. The skeletal frame, which I just have referred to like Elizarus technique, is a modification of the concept of the fracture bed where you give a support from the exterior and the fracture is corrected. So these fracture beds now are limited to operating room only. During surgery, till the nails are fixed, the bone may be kept in a reduced condition by using exactly the same principle as mentioned by Sushrutha. That's the fracture beds of different varieties. Now, the other varieties of the techniques are a minor bandages, a fracture which can be corrected with minor partial immobilization techniques. And it could be what we now use as a simple splints, Sheffield splints, simple splints where a metallic wire or a frame could be used as in case of a minor fracture like phalangeal bone fractures. In conditions, Sushrutha also has mentioned Anuna Aveshtya Pratyena, a small supportive structures could be used for supporting the bandage. Another major advantage of Sushrutha is in the context of the Talabhagna, where a normal part of the body can be used as a splint, and the idea of physiotherapy also is originally of Sushrutha. Now, In case normal part of the body is also called as body taping now. In case of Hastatala Bhagna, Sushrutha has mentioned the same, like when there is an injury to one of the hands, the other hand could be used as a splint and then it could be immobilized. Now, one of the very popular form of the treatment which is done in case of the phalangeal fractures now could be, if the other finger is normal, you make use of the other finger as a splint and put a bandage so that you will have a very perfect natural splintage, and it allows for certain amount of movement. The complications of the rigidity contractures would be the least and comparatively very comfortable to the patient even. So that's the body taping, and that idea is originally about Sushrutha. Then another basic idea of Sushrutha in the orthopedic management would be the taking care of the hematome. One of the most troublesome complications which can occur during the fracture management is a hematoma developing at the area and resulting in sepsis as such. Now, to ensure that there is no hematoma formed, you now have many techniques adopted. Hemostasis techniques are adopted. Sushrutha has used a very simple mechanism of a penetrating needle penetration and aspiration at the site. Now you have many sophisticated techniques as such. Complications of that kind of injury are quite more troublesome now in case of the fingers injuries, minor injuries of the fingers and nail beds, where the blood clot would be quite troublesome, and to reduce the blood clot, either it could be a simple aspiration or you may have now many more sophisticated techniques of reducing that. We will not go into the detail of that now. Then the other sophisticated basic ideas of physiology used in the fracture management is in case of fractures of the thorax and a possible penetrating injury into the pleura, the major complication will be the air being sucked into the pleura and a pneumothorax developing. To prevent the pneumothorax, now we use a thoracic drainage tube. A tube is inserted into the thoracic cage and it is kept in a fluid bottle so that the air doesn't get sucked in. But this idea is originally from Sushrutha's idea, but Sushrutha's technique was something different. Instead of keeping the tube dipped in water, Sushrutha had kept the patient dipped in an oil tub. So in a Parshukasti Bhagna, the patient would be kept in Tailapurna Katahe va Dronyam va Shaye Aram. In a Tailapurna Kataha, patient would be kept in so that there will be a oil seal, air will not be sucked. The modification which is done now would be, instead of keeping the patient in oil tub, you insert a tube and that tube is dipped in a seal, water seal or a fluid seal, water or oil, so that the air doesn't get sucked in. That's the modification which is done in around 5,000 years. But basic idea is originally of Sushrutha, that you have to prevent the air being sucked in. Then in anatomically sensitive areas, a blind manipulation is always quite troublesome, and this is what Sushrutha has mentioned, like in a Kurpara sandhimukta, in case of the dislocations of the elbow joint, you have to be very careful, and it's not that you have to reduce the fracture blindly, it has to be with anumarjana, a very delicate handling is necessary. And this is exactly a very important issue in case of the elbow joint dislocation. Just we have referred to earlier also about this issue. In a elbow joint dislocation, one of the delicate issue is the coronoid process, which is a very small bone, delicate bone, which gets into the supraorbital fossa and gets entangled. And any blind handling of this can result in more troublesome complications. And it has to be very careful, very delicate handling. And unless you are experienced, a dislocation of the elbow cannot be handled successfully, and blind handling can really give more complications than really the injury. So, and the basic technique is in theory is the same. You have to put a delicate pressure, ensure that that coronoid process is displaced from the supraorbital notch, and then you have to go for the flexion and extension, and that gets reduced as such. And similarly, another issue where you have certain anatomical specialties which have to be considered during the reduction is the mandibular dislocation. In the mandibular dislocation, once the mandible gets displaced and gets into the anterior portion as such, then patient's mouth will be kept open. So in such a condition, if anyone attempts to close the mouth, he will break the bone here at the styloid process area, the bone will be broken. So instead, the method of dealing with is that you have to insert your finger into the mouth, press the molar to down so that the bone displaced bone will be again back to the original posture, and then close the mouth and put a bandage. And that's exactly what Sushrutha has said is a Hanvastini Samaniya Hanusandavisamhate. In case of the Hanvasti Bhagna, you have to put a downward pressure, and then Panchangi Bhagna is to be used as such. This is the technique of mandibular dislocation. Then another basic idea of orthopedic discipline is the corrective osteotomy, particularly in case of a malinated fracture or maybe congenital abnormalities of the bones where the shapes of the bones are abnormal. A corrective osteotomy is another advanced technique. Of course, the technique is more sophisticated. You may make use of the CAD design instruments where the correction can be calculated by computers, and then the piece of the bone either is removed and then it could be corrected. Sushrutha has mentioned that original idea of that corrective osteotomy in case of a compound fracture, a malinated fracture. And in a malinated fracture, you have to refracture, and then whatever that extra bone has to be removed, and you have to reunite that bone as such. So Kandapagna Prorudeto, Vishama Ulpada Samhita Kandapagna is the malinated fracture. In that condition, Aputya Samaya Pagnam, the fracture has to be broken and a piece of the bone may have to be removed. And a piece of the bone may also have to be removed in case of a compound injury where the bone has become projected out. It's also a debridement of a open fracture. Sushrutha has mentioned the same in case of a Vranabhagna, Savranabhagna, Kalpayet Nigatam Shushkam Vranante Asti Samahitaha. When there is a projection of the bone over the wound surface, remove that area, and that you will have to ensure the wound has healed. Now, in the current technique, you have a special advantage of bone graft. Sushrutha has not mentioned about the bone graft, but now we have a advantage of the bone graft and the plastic surgical techniques where the skin tissue also can be corrected, and hence the result can be much better. But basic idea is to remove that portion of the bone which cannot be otherwise corrected is the same debridement, and either a bone graft or a fixation with the skeletal frame also would be the other alternative which we have now, which can be adopted, but basic principle is exactly of Sushrutha. Another unique idea of Sushrutha in the management of these injuries are in case of the injuries to the teeth. Injuries to the teeth, as I said, now is not an orthopedic discipline, it's about a dentistry, but Sushrutha has considered them in the context of the Bhagna. And in case of the teeth injuries also, you have to decide whether the teeth can be salvaged or not. If the teeth cannot be salvaged, and injury is quite severe and in an old aged person, they can be removed. But if the teeth can be salvaged and the patient is a relatively younger age person, the teeth has to be re-implanted. The tooth has to be re-implanted into the socket, and to reduce the movement of the teeth, the patient has to be fed with a tube. So feeding tube used in case of a medical emergency is originally of Sushrutha. Sushrutha had used a Utpala Patra. Now we may use a synthetic material like plastic. The tube could be used for feeding as such. Then another unique idea of Sushrutha in the management of the fracture is the plastic surgery concept of molding. In case of the cartilaginous injuries of the teeth of the nose or the ear, Sushrutha has suggested to mold that in the nose to keep the nose in gap. You have to insert a tube, and over the tube the cartilage has to be repositioned. Or in case of the ear also, pin of the ear also, that has to be repositioned with the grafts or molds. That whole idea of the molding for the tissue modification as a basic idea of the plastic surgery is originally of Sushrutha in the context of the same cartilaginous tract. Now, of course, that molding technology has now gone quite long distance, covered a long distance. You have very sophisticated tools of molding where any organ can be replaced with the molds, or the shape can be of your choice. Now, another idea of Sushrutha is a gradual progressive filling of the gap as the healing process occurs. Now, it's again a unique idea. In case of a fracture of the skull where there is a penetrating injury, Sushrutha has suggested the management of the fracture by closing this injury with the hair tuft, and then the tuft could be, the hair from the tuft can gradually remove day by day so that the area could be covered. Of course, that kind of a technique now is not practiced. It's a unique idea of Sushrutha mentioned that. The basic idea of preventing the complications and reducing the possible deformities of the fracture is what we call as the physiotherapy. And the basic idea of the physiotherapy is a gradual, progressive increase in the load over the organ of the body so that that organ of the body gains sufficient strength. And this idea is originally of Sushrutha. In the context of Talabhadna, Sushrutha has mentioned this context, this therapy as Mutpindam Dharayat Purvam Lavanam Chattada Param Haste Jasapalaiva Priya Pashana Dharanam. So, in a case of fractures of the carpal bones, and once the union has occurred, to facilitate the gradual regaining of the functions, initially the person is made to hold a soft compressible structure like a wet soil ball. Then once he has gained that strength, then go to a lavana, a salt ball, or it could be a piece of hard stone. So it's gaining strength. The whole idea of physiotherapy, which is now a very sophisticated branch, and we have lots of other technological innovations in that, would be based upon the basic idea of a gradual progressive increase in the load step by step to improve the functions. Then another idea, unique idea of Sushrutha in the orthopedic management is dealing with the non-united fractures. In the non-united fractures, what Sushrutha has suggested is applying of Swedana over the area and then attempting to unite the fracture again by reduction. Of course, now in the present day situation, you have an extra advantage of the bone graft, where a bone can be used from other areas, reserve areas of the body, and the gap can be filled up and a better result can be achieved. Then a soft tissue trauma is another of the troublesome conditions in case of orthopedic trauma management. You will have to confirm whether the injury is really of the bone or not, and a soft tissue trauma also can be quite troublesome, particularly when it involves the tendons and the ligament. And what Sushrutha has suggested is even in that soft tissue trauma, where there is no fractures but there is a swelling, a Shita Pradeha and Seka are to be applied over the area. In the current practice, the soft tissue trauma has become quite troublesome because a clinical diagnosis often can be misleading. So you need to have a sophisticated investigation like MRI scans to assess the tendon injuries or the cartilaginous injuries, and most of the times the outcome would be poorer as such. Then certain of the specific management mentioned by Sushrutha is about the basti and the nasya, which are not used in the contemporary practice. In case of Urdhvakaya Bhagna, nasya is Karnapurna or nasya can be used, whereas in Adhakaya Bhagna, basti are the suggested treatment which are mentioned by Sushrutha, which are not used in the contemporary practice. But if we adopt those, definitely the results can be better. Anyway, then the final prognosis of the fractures also are mentioned by Sushrutha depending upon the type of the fracture as well as the other factors, the fact which gives you a clear-cut idea of how Sushrutha had assessed these clinically. Churnita, Chinna, Adipatita, Madhyanugata are Krishasadhya by their own phenomena because injury is quite severe. Similarly, Krisha, Vruddha, Bala, Kshatakshina, Pushta, Shwasi are the patients who are emaciated, and then old aged patients. With the young age, of course, there is a bit of controversy, we'll come to that part also. Patients who have a systemic disorder like Kshatakshina, Pushta, etc., it will be quite difficult to manage. All the sandhimuktas are difficult to be managed. Now, as far as the younger age is considered, Sushrutha gives a very clear idea, like the healing of the fracture will be faster in younger age, but it will be difficult to immobilize a child, and hence it will be having a poorer prognosis, though the time taken for the union in younger age is shorter than the older age as such. Similarly, depending upon the anatomical factors also, a Katibhagna, a fracture of the pelvic bone, or a fractures of the thoracic bones, or head injuries, Kapalasti, Lalata in the head bone, or thoracic injuries, they are always having a poorer prognosis because of the possible accompanying complications as such. A congenital abnormality of the bone, like osteogenesis imperfecta, that's adito etcha durjatam. A aditah etcha durjatam. A durjata asti is a congenital deformity, also makes the prognosis poor. Or any of the fracture conditions where there will be a undue mobilization during the management would be again difficult to be managed, and outcome also will be depending upon the willpower of the patient, anatmavadaha, and nourishment of the patient, alpashanaha. If the patient's nourishment is poor, patient doesn't have a sufficient willpower to deal with, or a vata prakriti patient also would be having a poorer prognosis as such. In general, a patient in younger age, prasame vaisityam bhugnam sukaramabhishetat. In younger age, the time taken for the healing would be shorter, and whereas hence Sushrutha has said that the minimum duration for the union of the fracture is 1 month. Now, when we discussed about the fracture healing, we just refer to that minimum time taken for the union as 3 weeks. Sushrutha had given an extra safety precaution to consider that as 1 month. So, in a young age, when there are no complications, the time taken for the union of the fracture, according to Sushrutha, is 1 month, whereas now we consider this as 3 weeks. And in the older age, naturally, it takes more time, and the duration would be longer as such. The osteogenesis imperfecta is a congenital pathology where the prognosis could be poor. During the management of the fracture, the other issues are you will have to consider the dietary factors also. The nourishment of the patient has to be maintained, and as a dietary precautions, person needs to be avoided with the lavana, katuka, kshara aharas, and rigorous exercise like sexual copulation and exercises have to be avoided. A nourishing diet like chali, kshira, and particularly Greenstick kshira is a sadhya prasuta goho kshira. The milk collected from a cow after the first delivery, which would have more nourishing content, they are used as such. Specific medications also are suggested by Sushrutha for both rich patient as well as a poor patient. A rich patient, it could be a Gandha Taila, which will be very costly, whereas a poor patient, an alternative where a simpler yoga, comparatively cheaper yoga could be used for both local as well as systemic management. The specific medications also are mentioned in the management of the fracture. Ultimately, the target of the fracture management would be to ensure that there is no septic complications, because once the sepsis occurs, the outcome would be poorer, and hence you have to ensure that the sepsis doesn't occur with all the precautions. So you will have to take all the precautions to ensure that the paka doesn't occur. And the final outcome would be where there would be no anatomical deformity, no functional deformity, and the patient would be perfectly normal. Bhagnam sandhim manamidham ashinangam anulbanam sukachesta pracharamcha samhagam samyagadisheta. That's about the ultimate outcome, the target of the fracture management. To conclude, clinical assessment and management of the fracture described by Sushrutha is the basis of the current orthopedic discipline, and in some areas, Sushrutha has given you more detailed and more practical, clinically approaches, whereas now you have somewhat a higher level of technologies based upon the basic principles. With that, let me conclude. Thank you, and I will be happy to answer any of the questions.
Thank you so much, sir. We are really indebted to have heard from you today. Sir, there are some questions, sir. Sir, please suggest internal medications in Ayurveda to facilitate union to manage pain and inflammation.
Okay, Gandha Taila is mentioned by Sushrutha, but practically to have that Gandha Taila would be difficult. So, what I do in my practice is I use Gokshiradi Gugulu and Punarnamandura or Lakshadi Gugulu as a prescriptions usually used for Sandhana as well as to reduce the pain and swelling. Shotagna.
Thank you, sir. There is one question. How to understand Asthi Vivaragata Shalya mentioned in Pranashta Shalya as different from Majjanugata type of Kandabhagna?
Okay, the Madhyanugata is a injury result of the injury. Asti Vivaragata Shalya is a Shalya, a foreign body, or maybe a septic complication which occurs in the bone marrow. So Asti Vivaragata Shalya is a complication of a foreign body. Madhyanugata is a complication of injury where the madhya is displaced and there will be an embolism. It's not a pathology of the bone, this fat embolism would be the complication where the madhya is displaced into the vessels and then the vessels get blocked as such. So that's the basic difference.
Thank you, sir. Sir, how do we manage patient with malunion due to improper application of cast?
Improper application of repeat the question.
How
Okay.
do we manage?
See, once there is a malunion and malunion has occurred, it is a purely surgical condition. Sushrutha also has mentioned the surgical treatment. Apothya samayat bagnam, that is the treatment. Now also is the surgical treatment. Of course, the technique is difficult to manage. Outcome is also not very predictable, but it's a primarily surgical treatment.
Thank you, sir. Sir, treatment of osteogenesis imperfecta.
Virtually there is no curative treatment because it is a genetic pathology, and all that you have to do is reduce the possibility of the fractures occurring in that by taking protective measures. So that is the only treatment. There is no known curative treatment. And certain varieties of that osteogenesis imperfecta, if the person survives up to age of around 15 to 16, then gradually the complications will be lesser. Most of the patients succumb before that age. So virtually there is no known curative treatment anywhere in the world. So all that treatment now is a palliative treatment where you can give some nourishment to the patient and then ensure that there is no fracture. So protective regimes have to be taken as such.
Thank you, sir. Sir, are Pichita type of Sadhyovrana and Pichita Kandabhagna same? How
No. Pichita Vrana is again a complex injury, but it is about the Vrana in the Vrana Chikitsa. Pichita Bhagna is about the bone injury where the stress is given to the bone. Say Pichita Vrana, the description is not about the bone injuries. Whereas in case of the Pichita Bhagna, the whole area has become flatter. Pichitam Pruchitam Gatam Analpashokam. And so they are two different issues. A Pichita Vrana may involve a bone or may not involve a bone. But when we say Pichita Bhagna, there is an essential involvement of the bone. That's the difference.
Thank you, sir. Sir, how does Nasya help in Bhagna?
Of course, that kind of when a practice is not done regularly now, in a real fracture to use NSA is not done now, but that's exactly what's mentioned by Sushrutha. Practically the problem is whenever you have a patient with a head injury, you will always be worried more about the possible complications occurring in the intracranial area, and you rarely get an opportunity to manage that condition. And hence, I don't have a practical experience. That's what is mentioned by Sushrutha as a unique step. Though in a fracture, we may not use Nasya, but in many other injuries or many other complications, later complications of the injuries, where the patient may have a headache, sinusitis, or so on, Nasya does help to a certain extent.
Thank you, sir. Sir, first aid during the fracture.
First aid is the first of the thing is you have to assess where the fracture is, and then mobilization of the patient. When the patient has to be moved, there should not be aggravation of the injury. So that's again a very detailed protocol. You will have to ensure that when the patient is mobilized, you have to give a support to the area where the injury has occurred. Then vital functions have to be taken care of. You have to assess the breathing as usual in the first aid, like vital functions, pulse rate and breathing has to be assessed, and when there is a need to support, you have to support. Ensure the air passages clearly. And then the pain management. That's also a part of the first aid management. Assessment of the other accompanied complications like head injury or injury to the lungs, they need to be taken special care of, which is a very detailed issue. We may not be able to go into that detail, but the important is you have to ensure that the other patient survives till he gets an expert to deal with those complications. That's the first thing.
Thank you, sir. Namaste, sir. Treatment of Pichita Bhagna, that is compression fracture in contemporary and Ayurveda.
See, in the contemporary, in any comminuted fracture now is a surgical condition. It needs to be treated with any internal fixation measures, depending upon the amount of the injury. Either it could be a nail or a screw or a wire, that depends upon the location. Sushrutha has considered this as a asadhya. In the Krishasadhya conditions, Pichita Bhagna is included. Sushrutha has not mentioned any specific measures to treat with the Pichita Bhagna.
Thank you, sir. I think there are no more questions on the chat box. Thank you so much, sir. So now
Sir, actually, Nagashri, one nimsham.
yes, ma'am.
Sir, actually, radiologically, the union of fracture will be, I mean, if pathological union will be seen, but the radiologically, the X-rays will show late, no, sir? How long it takes?
I'm not getting the question. See, union is assessed clinically as well as radiologically.
Yeah, clinically will be fine, but radiologically it will be not displayed very soon on X-rays.
I think, see, once the callus is formed, callus can be assessed radiologically better. So, to ensure like whether you can put a load on the bone or not in a deal with a patient of fracture, the question is when the patient can start with the normal functioning, regaining the function. So, if it is that's the question. You will have to depend upon the radiological features more than clinical. So, many times what happens is clinically, as long as you put the load, the patient may feel comfortable. But once the load is put in, if that can be again recurrence of the injury, which complication can be avoided if you have assessed radiologically. If radiologically the callus is not proper, it's better to postpone that weak padding. So, in all other conditions, clinical assessment is always superior to radiological assessment. But in a fracture management, radiological assessment has to be given some extra edge over the clinical assessment.
Okay. Most of the time, the fracture will be along with the open wound. So, what should be addressed first?
There, the wound has to be treated first. Now, of course, you have some facilities of treating them simultaneously. Sushrutha's idea is the Vrana has to be treated first and then the Bhagna has to be treated, which will delay the total course. But in the present day situation, because now you have more sophisticated facilities and the techniques of suturing the wound separately as well as the fractures being managed, and even the surgical techniques like our internal fixation techniques, that's not a major issue. Dealing of wound as a separate issue is not a major issue in the contemporary situation because we have more sophistication. Sushrutha's idea is the wound has to be treated first and then the fracture has to be treated. Of course, even now, in many complex injuries where you have very serious bone injury, the same principle is adopted. Then you do not have the other options are not possible. I think I have shown you an image of the same where a bone is removed and then a skeletal frame is used. So in this condition, when you have this image, that area of the bone has to be filled with a bone graft only after the wound has recovered. Septic complications have reduced and the wound has recovered. So same principle could be adopted. So the choice, now you have more choices than what Sushrutha has said. That's true.
Thank you, sir. Sir, there are more questions, sir. Intramedullary rods or nails once put, is it necessary to be taken out once the bones are united?
That also depends upon the, okay, all right. That also depends upon the choice as well as the type of material. Materials used earlier were iridium and they would be more reactive and that iridium rods may have to be removed. But now these days you have more sophisticated materials which can remain in the body for longer duration and there are many loha purushas, persons with the rods intact in the body. So whether they need to be removed or not will be depending upon the context specific. I would not make a generalized statement on that. So once you are sure that the bone has gained sufficient strength and there will be no complications, nail can be removed. The general principle is it's better to remove these foreign body wherever possible. That's the general principle. But practically, it has to be decided based upon patient specific status.
Thank you, sir. How to manage the post-operative pain on OPD basis?
Post-operative pain, of course, you have to, one is in fracture, pain is always due to movement. So once you have immobilized, the complexity of the pain is reduced. Then the symptomatic treatment, the other way is the symptomatic treatment. The major portion is to ensure that there is no movement between the ends of the bones. Once you have immobilized the bone, pain becomes a relatively minor issue. It may not be quite severe. Then the pain management has to be the specific drugs like pain reducing drugs. So whether it's Ayurvedic drug or modern drug, that depends upon your choice, your patients as such.
Thank you, sir. So treatment of compartment syndrome.
That's again, primarily it's surgical. You need to correct that surgically. That's what's the primarily, principally. But practically what happens is many times even that surgical treatment would have a poorer prognosis. Outcome will be poorer. Once the nerves are compressed, surgical treatment also may not give sufficient result. So the other options which we can try and where we have seen clinically that the results are better would be the Posterior. Many of the patients with that narrow compartment syndromes, they respond very well to Posterior. It may be repeated, gives somewhat better results. I don't say that that gets cured, but comparatively, the outcome would be better than a surgical intervention.
Thank you, sir. Sir, there are few more questions. Shall we continue or?
Maybe by 4 o'clock I have to go to my clinic and see the patients. So till then I am free.
Okay, sir. Sir, how to manage sepsis through Ayurvedic treatment?
How to manage?
Sepsis through Ayurvedic treatment.
See, prevention of the sepsis is always more important. Whether it's Ayurveda modern, that's not the question. So wherever possible, sepsis has to be prevented by taking meticulous aseptic precautions. Then it's not necessary that every patient has to be treated with an antibiotic. Only when the sepsis is very severe and the total leukocyte count is very high, like more than 18,000, you may need an antibiotic. Otherwise, it can be treated based upon the dosha lakshanas. And most of the time the sepsis would be presenting with the pitta prakopita dosha lakshanas. And the very common prescription which I use in case of septic complication is Triphala Gugulu Gandhakarasayana. Very common, not necessarily the same, depends upon the patient's dosha lakshanas.
Thank you, sir. So there is a last question, sir. Will Majja Basti help in Bhagna?
I have not tried that. I don't.
Thank you, sir. Sir, now I request Dr. Shilpa Madam for the vote of thanks.
Thank you.
Thank you, sir. It was really an elaborative, informative session. Indeed, always whenever we listen to your session talk, we feel that you are an esteemed speaker with excellent clinician, par excellence orator. Every time you prove the same, sir. Thank you. On behalf of our GAMC Department of Shalya PG studies and all my faculty and from my students, I thank you wholeheartedly, sir. We had a very great session along with the interaction. Thank you, sir. We hope to continue the same cooperation in future, sir. Thank you.
Thank you, ma'am. Since this is a 6-day lecture series, let me remind everyone of tomorrow's session, that is by Dr. Srinivasan Mavanur Narayan, on the topic Basic Principles and Application of Radiology from 6 p.m. to 7 p.m. Thank you, sir. Thank you, one and all.